Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar. The Spark theme for June is Child and Youth Mental Health. I'm Michelle Bhatia, your host for the next hour. Children's Healthcare Canada acknowledges that our offices located in Ottawa are on the unceded, unsurrendered territory of the Algonquin and Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this community, our province, and the country. We are delighted to speak with Christine Schwartz to bring you children's mental health research messages for informing policy. Before we begin, we invite you to answer a few quick poll questions for us. Please note that you will have to answer all 3 questions to submit your response. So I see the questions have been launched. So while you're responding, I would like to introduce our speaker for today. Christine is a psychologist whose work focuses on the mental health needs of children and youth. She is the lead scientific writer for the Children's Mental Health Research Quarterly, an electronic publication designed to inform policymakers, practitioners, and the public about new research in children's mental health. Christine has also co-authored commissioned reports and peer-reviewed articles on a variety of topics related to children's mental health, including public policies to support the social and emotional well-being of all children. In addition, Christine has a clinical psychology practice which focuses on providing evidence-based mental health services to adolescents who are in conflict with the law. During the presentation, we welcome you to share your reflections and then connect with others on the line via the chat box and type your questions in the Q&A box, which we will pose at the end of the webinar. It is now my pleasure to pass the mic to Christine.
Wonderful. Thank you so much. I'm just going to be sharing the talk now. And I am so pleased by this opportunity to discuss how research can inform policy in children's mental health. My talk today is going to be based on 2 papers authored by the team at the Children's Health Policy Center, one on the prevalence of childhood mental disorders and the other on effective interventions for addressing them. Both papers were a team effort, and I'm also very pleased to be having one member of the team joining for the talk today, Donna Yoon, who's a research manager at the center. And before we dive into the data, I also want to acknowledge that I'm coming to you today from the unceded territories of the Lekwungen people, commonly also known as Victoria, BC. And before we dive into the data on prevalence and effective interventions, I just want to spend a wee bit of time talking about the impact of childhood mental disorders. They can have a profound consequence on kids who are affected. When a child has a mental disorder, what it means is that the symptoms they're experiencing are severe enough to cause considerable distress and also to interfere with their ability to fully participate in situations like their home, their schools, and in the community. It also means that the disorder impedes their healthy development and can lead to social problems, so things like being excluded from important recreational activities. And if the disorder is untreated, they will often persist into adulthood. And this can dramatically affect a child's life, leading to undereducation, underemployment, and even early mortality in some cases. And also, when a child has a mental disorder, the child's family also often pays a price. One study found that for parents of a child who had a mental disorder, they were more likely than parents of a child with a physical health condition to reduce their work hours or end their employment altogether. The same study found that these parents were more likely to spend a significant amount of time looking for childcare than parents of a child with a physical health problem. And what we also recognize is there can be some significant financial costs. So things like due to lost work, and as well out-of-pocket expenses for treatments that aren't publicly funded. And in addition, childhood mental disorders also have a high impact on society. They are currently the leading cause of childhood disability, and in Canada, the cost of these disorders is estimated to be more than $76 billion each year. And now, turning to how using research can inform policy. To best meet the mental health needs of children, we really do need to understand how many are impacted by mental disorders. We also recognize that some folks may question whether it's worth spending money to collect the data on the prevalence of childhood mental disorders. We think there are actually some very compelling reasons to do so. First, we recognize that policymakers are now increasingly using data to drive their decision making. In fact, the funding for our prevalence study that I'm going to be diving into was provided by BC's Ministry of Child and Family Development, Children and Youth Mental Health Policy Branch. So they're clearly very interested in obtaining this data. As well, if we want to have adequate funding to ensure prevention and treatment interventions can actually reach all kids in need, we do need to have accurate estimates of the numbers of kids impacted. And finally, when we track the rates of disorders over time, we also actually gather information on how well we're doing to meet the mental health needs of children. And recognizing this importance of the prevalence data, we conducted a systematic review and meta-analysis. We set a very high standard for the studies we were going to include because we knew for us accuracy was important, and also policymakers rely on high quality data. So what we did is we focused on epidemiological data because these data are particularly good at estimating rates of disorders within populations. We also required that the surveys include large representative samples of kids. They had to be conducted in high-income countries, again, for policy relevance. We needed to ensure that the outcomes were going to be applicable to Canada. As well, the studies had to use established measures to identify disorders. So this included diagnostic standards set by the ICD and the DSM, as well as using an interview schedule that assessed both symptoms and impairment. And the studies also had to report on 3 or more individual or groups of disorders, as well as provide an estimate of the number of children overall impacted by any disorder. And even with this really rigorous standard, we still were able to include 14 studies that met our inclusion criteria. They included data from 11 countries, including 1 survey of Canadian kids. And when we pooled all the data together, we had around 62,000 children. We had excellent coverage by age, from kids as young as 4 all the way up to 18. And all of the studies used very recent or current editions of the DSM or the ICD. And to count as a disorder, the level of impairment caused by the condition had to be at least moderate. And for many of the studies, it was actually severe. And here's what we found. At any given time, approximately 12.7% of kids will meet criteria for a mental disorder. And when you apply this to population rates in Canada, it works out to be nearly 800,000 kids. And because all of the kids were experiencing moderate to severe impairment, the disorders were interfering with their daily functioning. And for many of the kids, the burden didn't end with just one disorder. For 26.5% of the children who had one disorder, they met criteria for 2 or more disorders concurrently. And then when we broke it down and looked at the specific disorders, the category of anxiety disorders were the most prevalent at 5.2%. But then you also see high rates for things like ADHD, oppositional defiant disorder, substance use disorder, as well as major depression. And these data have many use for policymakers. So for example, the funders of this study, the Child and Youth Mental Health Policy Branch, they can use this data to estimate the number of children who will be seeking treatment, as well as the conditions they're likely going to be seeking treatment for. And in our review, what we also did is try to take a look at how many kids who had a disorder were receiving any kind of services for them. And 8 out of the 14 studies we included were able to provide this data. And when we combined the information from those 8 studies, the numbers we found were quite troubling. Less than half of the kids with a disorder got any services whatsoever for them. And when you apply that to the numbers of Canadian kids, this would equal around 445,000 children in Canada with disorders who likely aren't receiving any treatment at all for them. And at our center, we question if failing to provide treatment for this many kids with diabetes or cancer would be acceptable. And if it's not, why would it be okay for kids with mental disorders? And beyond reaching more children with treatments, we also need to be certain that the interventions that are reaching kids are effective. And to this end, we conducted another review to identify effective mental health interventions. This study was also funded by the Child and Youth Mental Health Policy Branch, once again highlighting how policymakers are increasingly focused on using research evidence. More specifically for our policy partners, they wanted to ensure that the treatments being offered by the clinicians were indeed effective. And once again, in our research, we set a really rigorous standard. We wanted to make sure that those treatments that we were labeling as having evidence of effectiveness really reached a high standard with their methodology so that we could be certain of the results. And so to meet our standard, what we required was evidence of statistically significant reductions in diagnoses or symptoms from at least 2 randomized controlled trials. We set this methodology knowing that it was a very high standard and gave us more confidence in the outcomes as well. Researchers had to have outcome data for at least 80% of the kids who had been randomized, or they had to do a specific analysis to adjust for missing data, so we could be certain that the findings really did have wide applicability. The studies also had to assess outcomes for at least 3 months after the intervention, so we could have certainty that the benefits lasted as long as the intervention did and sometime thereafter. And for most of the interventions, at least one person who provided the outcome ratings had to be unaware of whether the child was receiving the intervention or were randomized to the comparison condition, because we know that if people are aware of the treatment condition, it can influence ratings. And even with this really rigorous standard, we were still able to accept 113 randomized controlled trials and 5 systematic reviews. And turning to what we found, beginning with anxiety, the most prevalent disorder, there was great news in that we found effective interventions both for prevention, psychosocial treatment, and medication. What we found was cognitive behavioral therapy worked for both prevention and treatment. And cognitive behavioral therapy is very much a skills-based intervention. So teaching kids how to identify and recognize the worry thoughts that are in their head and how to challenge them when they're inaccurate and come up with more helpful thinking. Also, behavioral component, having the kids face many of their feared situations. And also good evidence for medications. Fluoxetine and sertraline were both found to be effective. Both had side effects, nausea for the fluoxetine and drowsiness for sertraline. And turning to the next most common disorder, ADHD. And for this, what we found was parent training was effective both at prevention and at treatment. And parent training involved things like helping parents increase their focus and attention when the child was engaging in positive on-task behaviors, and learning to not overly focus on the more negative behaviors. And it also, for the treatment, included multi-component programs. So those were the types of programs that combined a little bit from different interventions. So working directly with the kids with behaviors therapy, so increasing their on-focus, on-task behavior, social skills training, so helping them in their interactions with other children. As well, we found absolutely excellent evidence on 3 different medications: methylphenidate, dextroamphetamine, and atomoxetine. Looking at a combination of both oppositional defiant and conduct disorder, because the treatments are very similar, we combine them together. Once again, excellent evidence for parent training, both in terms of preventing the condition and treating them. And again, those multi-component programs that combined a number of different interventions, again, the behavior therapy, the social skills training. And in terms of medication, what we found was some evidence of effectiveness for risperidone, but for that medication, it also had frequent side effects that include fatigue and weight gain for kids. Moving on to the substance use disorders, once again, looking at those multi-component programs for both prevention and treatment, including things that, again, CBT comes out a winner. Also things like motivational interviewing, so helping young people recognize how changing their substance use may have benefit for them when they're at a point of just contemplating changing their use. And moving on to depression, again, cognitive behavioral therapy for both prevention and treatment, and then also for treatment, interpersonal psychotherapy. And once again, an effective medication in fluoxetine. And in the case of depression, the side effects included suicide attempts, suicidal thoughts, and headaches at greater rate than was found for placebo. Looking at autism spectrum disorder, 2 effective treatments reducing the core symptoms of the disorder. So behavior therapy, which focused on increasing kids' appropriate engagement in social interactions. And again, cognitive behavioral therapy, teaching kids specific skills like perspective taking and how to adapt their behavior to different situations. And moving on to obsessive-compulsive disorder, very strong evidence again in supporting it. Among the medications of the 4 listed, the fluoxetine stood out for having a more a less harmful, a more favorable side effect profile than the other medications. But again, the evidence for CBT was particularly strong. Looking at bipolar disorder, there were 3 different multi-component interventions tested in 4 different RCTs that reduced symptoms of the disorder. They all focused on education, problem solving, and communication skills, but importantly, almost all youth who were receiving those psychosocial treatments were also concurrently taking medications for bipolar disorder. And turning to the medications for the condition, lithium was found to be effective, but it also had a number of side effects, including excessive thirst and nausea. And now moving on to eating disorders, multi-component programs were effective in in preventing eating disorder symptoms. And one program was also effective in averting bulimia diagnoses. Family therapy was effective in helping more young people reach remission from anorexia and from bulimia. It involved the family developing a plan to restore the child's weight through eating meals together for the young people suffering from anorexia. And in terms of bulimia, it involved having the parent become more involved in the child's eating. And turning to the prevention and treatment of post-traumatic stress disorder, once again, CBT was effective for both. And looking at the final disorder, schizophrenia, 2 effective medications. Both had side effects though. For the first one, it was sedations and tremor. And for olanzapine, there was elevated prolactin levels and weight gain. And before I dive a bit deeper into how the findings from these 2 papers can assist the important work of policymakers, I just also want to situate our findings within a population health framework. So in other words, to help the greatest number of children, policymakers, practitioners, and researchers can do portions by focusing on each different of the 4 key components of the model. Turning to the first area, promoting the healthy development for all kids. One thing that all constituent groups can do is make sure that there are efforts to address the social determinants of mental health. And one key component to this is preventing avoidable adversities. We know that there are some adversities that increase the likelihood of a child developing a mental disorder. We also know that many of the adversities that children face are preventable. So we know that family socioeconomic disadvantage is a risk factor in several mental disorders, including for things like conduct disorder. But we also know that their policies can make a difference in this area. There's a long history in the Nordic countries of creating policies that can help reduce that disadvantage for families. So these countries like Denmark, Finland, Iceland, and Norway, they've reduced socioeconomic disparities through longstanding social programs that redistribute income. We've also had some experiments in this country when we've looked at income redistribution that have had positive effects for kids. So what this also means is sometimes policymakers that may not be directly involved in children's mental health can impact policies that do make a difference for kids' mental health. We also know that childhood maltreatment can have an outcome for children's mental health. Obviously for situations like post-traumatic stress disorder, but we also know that there are higher rates of certain disorders for kids who experience maltreatment, so things like anxiety disorders and again, conduct disorder. And what we know is policymakers can implement programs that have a proven track record in reducing childhood maltreatment. So things like programs like the Nurse Family Partnership, and we have examples in BC where policymakers have looked into the research evidence and are working to have it so the program is in 4 out of the 5 health regions in BC. And finally, we also know that policymakers can take steps to address racism and the ongoing impact of colonialism. One of the guideways for doing this work is the Truth and Reconciliation Report. There are actionable items that the federal and provincial governments have acted on that can make the lives of Indigenous people, and especially the children in our country, more equitable. Excuse me. And we also need to make sure that there are adequate investments in effective interventions. And the great news is that policymakers have lots of effective programs that they can invest in. This table is actually a summary of our effective interventions paper. And what you can see in terms of prevention, 8 of the 12 most common disorders, we have effective prevention interventions, and we have effective treatment interventions for all 12 of them. And what we also recognize is, because many children in Canada who need effective treatments aren't getting it, there's often a focus on reaching more kids with treatment. But what we also recognize is we have the ability to avert suffering. When there's a shift and there's greater investments in prevention, we can do more upstream work to prevent kids from actually developing these disorders. And by making these early investments in prevention, we can reduce both the suffering for kids and families, and also create less of a need for treatment down the road. And we know that even in times where there's challenges around getting enough effective treatments for kids, there are still jurisdictions where there's an increasing focus on prevention and making sure those investments are being tailored to interventions where we know that there's good evidence of success. And the final part of the model for public health in children's mental health is monitoring outcomes. And we also know that we can by monitoring outcomes, what we can do is take a look to make sure the investments we are making in children's mental health are actually paying off for children. So things like, if a new program is being instituted, taking a look to see that the outcomes are really benefiting children, doing ongoing monitoring of things like the prevalence of mental disorders to make sure that we are effectively reaching the number of kids we need to. And at the Children's Health Policy Center, we also recognize that policymakers often have to make really difficult choices in terms of spending of limited public health dollars. Because of this, we recognize that economic data can highlight the value in investing in children's mental health. The data is really continuing to build on how spending in this area pays off, both in terms of the well-being of kids and for society too. So what we do know is, by making investments in effective prevention programs, there truly can be long-term cost savings. One disorder that stands out is conduct disorder. We have good evidence that if we can prevent it, there can be long-term cost savings, by avoiding later spending in other areas like the youth criminal justice system. And again, we have good data on some specific programs. So once again, the Nurse-Family Partnership, when they've done economic evaluations, what they found is for every dollar invested, when you look at later on costs, there's a $6 savings for every dollar spent. And what we also have is evidence from other countries who've shown some success in making positive investments in children's mental health. And Australia really does stand out in this regard. They actually doubled the proportion of children receiving both prevention and treatment services. And they're also conducting ongoing surveys to see how they can continuously improve their services. They really have made those investments and have shown a pathway so how more kids can be reached with effective services. And we are very confident at the Children's Health Policy Center that researchers really can play a key role in helping more Canadian children reach optimal levels of mental health. When we produce research that's relevant and actionable by policymakers, we can make a difference in the lives of many children and substantially improve their mental health and their well-being. And we think this is a solid and worthwhile investment to make. And I just also want to acknowledge the funding sources for the research that we do. The Canadian Research Chairs Program, the Canadian Institute of Health Research, the BC Ministry of Children and Family Development, specifically the Child and Youth Mental Health Policy Branch, which funded two of the papers today, the Malphigian and Stern Foundations, and a disclosure that two team members who played a role in our research have also conducted an evaluation of the Nurse-Family Partnership. And now I am very happy to turn it over for questions and comments too.
Wonderful. Thank you so much, Christine, for this engaging presentation and sharing more about the research that you do at the Children's Health Policy Center. So I will just sort through the questions. And so while I'm doing that for our Q&A, we'd just like to ask a few quick poll questions for everyone to help us continue to improve our SPARK program. And you will have to select and answer for all 5 questions before submitting your response. Perfect. Thank you so much for your feedback, everyone. So now to pose our questions. So the first question I have is that funding for both of the reports featured in your talk was provided by policymakers within the BC government. So Christine, can you tell us a little bit more about the Children's Health Policy Center and how they were able to garner support from within the BC government?
Absolutely. So our centers had a long-standing relationship with the Child and Youth Mental Health Policy Branch. We've had a partnership that dates back to 2020. And I think part of the reason the partnership has been so successful is, one, having that very common goal of helping improve the mental health of children in the province. So fundamentally, both of our work always turns back to that key goal. And then the partnership has grown and developed over time, I think through mutual respect and understanding. And so for our work as researchers, we want to create research that is actionable, that policymakers, there's direct relevance for them. And as a part of that, it's ongoing dialogue. It's that the regular meetings we have with policymakers to understand what their concerns are, to understand what their goals are. And also as a part of this is an understanding also of the work we do. For us, there's a great importance of the academic rigor we bring to the research that we do. And it's an ongoing dialogue around how we can maintain our academic rigor at the same time creating research that is going to be usable and viable for researchers, or sorry, for policymakers. So it's that ongoing dialogue that we do have, and it's the ongoing communication around how the research is going to be used and what the goals of the research are. It's through those dialogues and communication, I think, that's forged a partnership that has been very long-standing and very successful, and has hopefully made an impact in the lives of kids in BC. So thank you so much for that question.
Perfect. Thank you so much, Christine. So the next question I have are, I know you sort of mentioned this a little bit, but what are the biggest barriers that you sort of see in that process of translating the research into actions in the work that you've done?
Fantastic, thank you. That's an excellent question. There can be a number of barriers faced by both researchers and by policymakers. For policymakers, they often have very limited budgets, and for our research group, we recognize that the dollars are limited and precious, and that investments have to be very carefully thought out. Excuse me. What we also recognize is we have to take into account the viability of interventions that could be potentially of interest within a given context. So, for example, one of the interventions that has had proven success in helping kids with significant behavior problems, multi-systemic therapy, has some really good research evidence. But what we also know for that particular model, the clinicians are on call 24 hours a day, and they have very small caseloads. What we recognize is, while there may be really good research evidence for that model, it wasn't going to be a good fit for the reality of the employees within the service branch. So there's a part where we need to recognize what the research may say, but what is actually going to work. And the good news when you're looking at research evidence, oftentimes what you can find is different interventions that will work better for a given center. So what we could do is find other effective interventions for kids who are having behavioral struggles that were deliverable. So there can often be challenges, but partially the way to solve them is to understand what the challenges are for the policymakers and for the practitioners, and also working collaboratively, brainstorming how to solve and overcome some of those challenges. So another excellent question. Thank you.
Wonderful. Thank you, Christine. So I have received a question from Loretta, and so she's a mom of a child with ADHD, learning disability, anxiety, and depression. And so she asks, what are your thoughts for medication? And what are the stats in terms of what you've seen of side effects versus the benefits?
So in terms specifically of medication for the anxiety component, there is good evidence of the effectiveness of some antidepressants like fluoxetine for anxiety. Of course, all of the medications do have side effects, fluoxetine among them. what we do know is we also have fantastic evidence for cognitive behavioral therapy, specifically for anxiety disorders, a really outstanding track record for actually disorder remission. And we also know that it can be very easily delivered to kids. So for cognitive behavioral therapy, it's things like identifying what the worry thoughts the young person is having. So for a young person, it might be, worrying about going to school and maybe some social judgment and helping challenge that. Again, the child, once they're ready, facing those feared situations. So oftentimes, clinicians will turn to using cognitive behavioral therapy as a first-line treatment, and then turn to medications if cognitive behavioral therapy hasn't had the impact that it could. Of course, with any medication, you'd want to make sure that the child is being regularly monitored for side effects, to make sure that the side effects aren't outweighing the benefits, and to ensure that the medications are having the benefits that are hoped for. So indeed, there are effective treatments for the anxiety component as well. At the Children's Health Policy Center, for our systematic review, we haven't focused on the learning disabilities, but indeed there are effective treatments to help kids who are experiencing some learning challenges as well. So there's indeed lots we can do to help kids. And again, I think raising the important fact that for many children, a quarter of them, if they're diagnosed with one disorder, that they're going to be experiencing other mental health challenges, so some learning challenges. So clinicians being ready to address the multiple needs of many children, as well as policymakers recognizing that this is what practitioners are going to be addressing, oftentimes multiple disorders. So thank you for that also.
Wonderful, thank you. So you noted that cognitive behavioral therapy was found to be an effective intervention for several disorders. So can you speak to the similarities and differences between how it is used to treat the different disorders?
Oh, more than happy to do so. Thank you. And so cognitive behavioral therapy, it's so worthwhile investing in training for practitioners so they have this skill set, because cognitive behavioral therapy, as I highlighted, is effective across so many different disorders. So there are fundamental components that cross different disorders. So regardless of the disorder, there's going to be the cognitive piece, or helping the child identify specific ways of thinking that are likely inaccurate and are unhelpful to them. As well, there's going to be a behavioral component that crosses, and it'll look different in different situations. So the behavioral component for a child who's experiencing anxiety or post-traumatic stress disorder, there's going to be an avoidance of things that create the fear. And the practitioner is going to be helping the child in that case by helping them be in situations that trigger the fear to help them recognize that they can overcome it. But for the behavioral component for a disorder like depression, it's going to look different. For a young person who's experiencing depression, what they're typically you're going to see for the behavioral changes is a reduction in pleasant activities and a reduction in productive activities. So for most people, they get that sense of joy and happiness when they engage in things they innately find fun or give them that sense that they've accomplished something. And for kids who are depressed, they stop doing a lot or reduce those activities. So the behavioral activation that the clinician is going to help a depressed child with is going to look different than an anxious child. For a depressed child, they may be focusing on getting back into the sports that they used to do before they were depressed. So even though the child doesn't feel like they necessarily want to go to soccer practice, encouraging them to try it out. For the thinking piece, for the anxious child, there's that focus on the fear, the what ifs. So the fear that something bad may happen to them. So fearing for a child who has separation anxiety disorder that they're going to be separated from their parents. So oftentimes their fear is going to be an overestimate. So they're fearing things that are unlikely to happen. Or conversely, they're fearing an outcome that could potentially happen, but they're underestimating their ability to cope with it. In contrast, for a young person who's experiencing depression, their unhelpful thoughts are more likely to be focused on negative views of themselves, negative views about the world around them, and negative views about their future. So in both cases, the practitioner is going to be working with that young person to help them identify the negative thoughts that are going through their head. And it can be challenging. Kids are usually just excellent at identifying the feelings, but it's a little bit harder for them to get the specific thoughts that are going through their heads. So a practitioner is going to work with them to catch those automatic thoughts. And then they're going to work with them to challenge those thoughts, to come up with something that's more helpful and more realistic. And they'll guide them through that. So for an anxious kid who's worried about negative social evaluations, some of the thought challenges might be things like, what's the real likelihood that Jenny's actually thinking about me? And if they are, that the thoughts are negative. So there's just some great applicability for CBT across these disorders. Again, those core components you're going to see them applied across the different disorders, but with some slight variations. So again, it's a great investment for policymakers to do training for their practitioners in CBT for those who are hard, who don't come with that skill set. So my answer to how CBT can be very translatable across the disorders, and thank you for that question as well.
Wonderful. Thank you, Christine. So in terms of reaching policymakers to make the changes, if there was one message that you could send to policymakers that are focused on this issue, what would that be?
Investing in children's health pays off. For me, there's a recognition that policymakers have a really tough job. They've got to answer for how they're putting their funding and their priorities. And I think for a lot of researchers and practitioners, we see the kids, we see the difference that positive mental health makes in their life, and it can tug at our heartstrings. And that's not to say it doesn't tug at the heartstrings for policymakers, but they also have to justify their investments. And I think oftentimes that economic argument is just such a solid one for policymakers to provide. And across so many of the different disorders, there's an increasing body of evidence about how these investments pay off. that things like the nurse-family partnership. When a policymaker first looks at the price tag and says, you know, this is a quote unquote expensive intervention. Nurses are limited. We're having trouble recruiting nurses as it is, and nurses' salaries cost a lot. And when you look at it at the front end and only focus on that, I think it could dissuade policymakers from making those kind of investments. However, when you look at the longer term data and when you measure the impact over time, you'll often see long-term gains. So as I had mentioned, you put the $1 into the kitty now, and later on down the road, you're going to get, you know, $6 back in savings in terms of those longer-term savings in things like youth justice. But what I also think is important too is to look at also some of the shorter term savings. What we recognize as governments who invest in those programs in the here and now, some of those long-term dollar savings may be 20 years down the road where it may not be the same government. So it's also highlighting the dollar savings that can occur more early. So in the case of nurse-family partnership, looking at some of the research has shown that the kids less likely to be maltreated, less likely to have a hospital admission. So also raising those cost savings in the shorter run. So for us, in terms of helping policymakers, it's the positive mental health outcomes coupled with making prudent financial decisions can be just such a persuasive argument. Again, we recognize policymakers want to do the best for kids, and helping them have the evidence about the investments that are really going to reach that goal. So thank you for that question also.
Wonderful. Yeah, I completely agree with that, everything you've said, Christine. So in your practice, post-pandemic, what are sort of like the biggest concerns you've seen coming from individuals that you work with, so the children and youth? What are sort of the biggest concerns that have come to you in your practice?
Oh, thanks for that question also. So I'd love to speak to both my practice as well as the general research findings, because one of the papers that we recently published is on the mental health impact of the pandemic. So what we do know for young people is definitely an increase in the number of children and youth experiencing anxiety, as well a great increase in the number of young people looking for services for eating disorders. So I think across the board for practitioners, those are things that they're definitely seeing changes in their practice. For my practice, most of my work is for kids who've come into conflict with the justice system. And in the work that I do, there was a considerable lull in referrals, because in BC, the court systems really did see considerably fewer cases. So that meant a shift, unfortunately for me, in that there were many young people that I would have loved to have been able to see and intervene with, but unfortunately there was a very large lag in the time that from when the offenses were committed to when I was able to see them. And it's probably surprising to a lot of people that even though I'm working with kids who come into conflict with the law, a lot of them still also experience problems with anxiety. I am definitely seeing an increase in the number of kids where that is a concern. Kids were sequestered in their home for a long time. In BC, of course, the pandemic response was different in different provinces. I live in a province where the schools, more kids were still able to access schools than in other provinces, but still kids didn't have that same opportunity for social engagement. And when they don't, what I'm seeing is a rise in anxiety in reference to social anxiety, a lot of fear of social judgment, and how to respond to that. And thankfully, though, I do feel well equipped to help kids work through that, and have seen the benefits of applying cognitive behavioral therapy to help kids. One of the things I do when I practice CBT with young people is I do warn them that what I'm going to be asking them to do is some really difficult tasks that I'm going to work with them to help them with their skills. But the kind of treatment that we're going to be doing, part of it is practicing in my office, but a large part of it is them taking it into their lives and practicing it day in and day out, and acknowledging and recognizing that it's hard work to do. I'm there to support them through it, but it's going to take their time and effort, and also knowing that that time and effort will pay off. So I am very privileged to work with kids that work really hard to address the challenges they're facing. Also with the kids I work with, substance use is a huge concern. The opioid crisis is most definitely a crisis in the province that I live in, as well as the kids I'm seeing. The kids I work with are court mandated to come and see me, so they are not coming voluntarily, but I work really hard to make sure the experience is as positive for them as I can make it, and then relying to address the substance use, heavily relying on skills through motivational interviewing, helping the young people see how making changes to their substance use can benefit them. So the pandemic has brought a lot of challenges to the lives of the kids I work with. And now it's sort of doing catch up to provide the services we can to help the kids, because the kids I work with, most of them are facing so many adversities and are so disadvantaged, and doing the best we can to help them, to put them on a better track. So I'm looking at this phase as a real opportunity to help the kids who kind of got left behind in the pandemic. So thank you for that question also.
Thank you so much, Christine. This has been really insightful. So thank you so much for sharing your time and your expertise with us today. So we have reached the end of our time today. And thank you so much to our audience members as well for joining in. And we really hope that you depart with some practical knowledge to bring back to your organization. So upcoming on Spark Live on June 21st, we have our third webinar of the month, Child and Youth Mental Health, Parental Concerns about Children's Learning, Development, and Mental Health, with Dr. Caitlin Bryant, as a psychologist and assistant director at Mary J. Wright Child and Youth Development Clinic. And on June 28th, we're excited to bring you another webinar, Collaborative Pathways to Engage Healthcare Professionals in Addressing Refugee Child and Youth Mental Health, with Dr. Mayesha Sayeda, who's a clinician scientist at the Center for School Mental Health and Adjunct Research Professor in the Applied Psychology Division in the Faculty of Education at Western. And in Spark Conversations, watch out for our next episode of the Spark Conversations podcast series, Navigating the Child and Youth Mental Health Crisis, Challenges and Opportunities, which will be launched on July 4th. And this episode will involve Season 3 podcast host Dr. Catherine Smart in conversation with special guest Dr. Javid Sakara. So stay tuned for details about our upcoming Spark webinars. And it's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions will be made available after the fact on our website. So thank you so much again to Christine. Thank you for joining us and for this great presentation. And hopefully we'll see many of you back here on Wednesday. Bye, everyone.